So with this, I'd like to introduce our next speaker to you, and this is Nathalie Wauthoz. I hope I pronounce it somehow correct. She obtained a PhD degree in biomedical and pharmaceutical sciences in 2011, and after several research stays, she is an associate professor since 2017 in Brussels, at the University in Brussels. She works on the development of DPIs to combat various different diseases. She works on as in vitro cell culture and in vivo preclinical models. And she will tell us about tumor exposure following the administration of an innovative cisplatin dry powder for inhalation. Nathalie, the floor is yours.
Thank you, Madam Chairman, for this kind introduction. So today it's very nice to be here after 3 years. So it's my pleasure to present our work about tumor exposure following the administration of an innovative cisplatin dry powder for inhalation at different dose levels and regimen in a lung carcinoma model. So as you probably know, lung cancer is one of the most frequent and the most fatal cancer in the world. And 85% of lung cancer are non-small cell lung cancer. It's usually diagnosed in elderly population at advanced stages where the survival rates are low. So nowadays, there is a gap between localized treatment that aims to remove the lung tumor physically and systemic treatment that combat the invasion from the solid tumor. So the systemic delivery of high doses of cytotoxic chemotherapy involves dose-limiting toxicities as well as treatment interruption that allows the whole body to recover, but including also the tumor tissues. And the risk of invasion begins from the tumor, where the drug concentration is often low and heterogeneously distributed from the blood vessels. So inhaled chemotherapy could be a new modality as a local-regional treatment to fill this gap by concentrating the delivered dose locally, and this dose will then diffuse by the same route as the cancerous cells. So inhaled chemotherapy has already been investigated in clinical trials up to phase 2, but only by nebulization, which presents major technical and clinical challenges. So to overcome them, we choose to use a disposable dry powder for inhalation and to develop an innovative dry powder for inhalation in the aim to modulate the lung pharmacokinetics in order to limit the local lung toxicities while exposing the lung tumor sufficiently to the released drug. So for that, we develop a dry powder for inhalation with controlled release, drug release properties by embedding cisplatin microcrystal with a lipid matrix and with sustained lung retention properties thanks to a pegylated excipient at the surface of the particles. So with this innovative formulation, the aim of this study was to determine how much the lung tumor is exposed to cisplatin after a single administration on day 6 post-tumor graft or after repeated administration from day 6 to day 10. So for this, we choose a murine lung carcinoma model that is not sensitive to cisplatin to avoid the impact of the dose level or the regimen on the tumor size. And after treatment, we collect the lung, we remove the lung tumor, and the lung tumor was then rinsed in 100 microliter of PBS. This provides the tumor fluid which corresponded to the tumor periphery. So after one single administration of 6-DPI 0.5 mg per kg, The PK profile and parameter reveals a high platinum concentration in lung tumor directly after the administration. This lasts up to 2 hours with very low elimination from the lung tumor with a half-life of 94 minutes. So for tumor-free lung, the high platinum concentration was rapidly eliminated with a half-life of 12 minutes. It was the same trend for the tumor-free. So these differences led to an area under the curves that was 10 times higher for lung tumor than for tumor-free lungs, which is very encouraging for this locoregional treatment. Moreover, the pulmonary delivery increased drastically the platinum concentration in lung tumor with a low systemic exposure in comparison to the IV administration of cisplatin at 2 mg per kg. So after that, repeated administration were made over one cycle of 5 days of treatment at different dose levels, 0.3, 0.5, or 1 mg per kg per day, at different regimens, once a day or every 2 days. And the biodistribution study in tumor-free lung, tumor-free plasma, and kidney was made at the Tmex previously observed during the PK study. That means at 2 hours. So the platinum concentration in the lung tumor were 4-fold and up to 6.5-fold higher in lung tumor than in tumor-free lung. The highest exposure was seen with the highest dose level and regimen, with the highest platinum concentration in lung tumor and in tumor-free, which seems to support the diffusion theory based on the gradient of concentration. Moreover, the biodistribution study showed non-significant platinum accumulation in healthy organs such as tumor-free lungs, plasma, or kidney in comparison to the single administration, independently of the dose level or the regimen. So the highest dose level and regimen led to the highest exposure for the lung tumor without affecting the healthy organs. So it was very encouraging to expose more the lung tumor without additional local or systemic toxicities. So besides this study, another study was made in a cisplatin-sensitive lung carcinoma. So you have more details of the results in poster 64. Briefly, the anti-tumor response in terms of tumor growth was investigated and revealed a dose-dependent anti-tumor, cytotoxic anti-tumor effect, as well as an anti-tumor immunogenic effect when combined to an anti-PD-1 therapy. And this immunogenic effect was due to an increased infiltration of CD8 T cells in the tumor microenvironment. So the good tumor penetration, as well as the dose-dependent cytotoxic effect and the immunogenic response, are very promising for this new modality in non-small cell lung cancer treatment. So to conclude, a high concentration of platinum was retrieved directly after the administration, and an increase in concentration was observed up to 2 hours. This was certainly due to a diffusion effect from the periphery to the core of the tumor and due to a very low elimination from the lung tumor. The higher the cumulative dose was, the higher the dose in the lung tumor was, which demonstrates a dose-dependent penetration into the tumor. Moreover, at the highest dose level and regimen, the lung tumor was more exposed to cisplatin without affecting the other healthy organs. This is promising for an increase in tumor exposure without involving additional local or systemic toxicities. And in addition, cis-DPI exerts a dose-dependent cytotoxic effect as well as an anti-tumor immunogenic response when combined with an anti-PD-1 therapy. So all these results are very promising for this new local regional modality in non-small cell lung cancer treatment. So to go further with this product, we have co-founded a spin-off company, Target Therapeutics, to evaluate it on advanced stage lung cancer patients treated with immunotherapy. And so our first clinical trials will be conducted in coming months. So thank you for your attention, and don't hesitate if you have any questions.
Thank you very much, Nathalie. Are there any questions from the audience? There is a question.
Hi, very nice talk. Can I ask you if you have any data to share with us on the aerodynamics of your particles?
Yes, not here, but the particles were, of course, evaluated with the next generation impactor and so on, and we have half of the dose, half of the delivered dose that is the fine particle fraction. So, and we have a high dose content of cisplatin in the particles, 50% of the drug content, so we can reach easily the dose the patient needs for the treatment. Thank you.
Maybe in line with that, there is a question coming via Slido, and that relates to the formulation characteristics. So how come that you actually obtain a 10 times higher AUC in a tumor lung versus a tumor-free lung? Is there some type of a targeting in your particles?
I don't think it's targeting. It's more because there are some physiopathological characteristics in the tumor that decrease the elimination of the particles because you have a lower vascularization due to the angiogenic process in comparison to the lung. So the elimination was lower. You don't have lymphatic drainage in the lung, in the lung tumor too. So it decreased the elimination. And also because you have a tumor that obstructs partly or completely the airways, you have an infection on the powder on the tumor that concentrate the formulation on the periphery, allowing the diffusion of the particles inside the tumor. Moreover, the tumor is a more denser tissue than the lung. And so in the lung, it's very, it is more eliminated by absorption or by mucociliary escalator. We have pegylation, so the alveolar macrophage clearance is limited. But yes, we observed these differences, and it was very interesting in our case.
Thank you. There is another question.
John Patton, Kendeba. This is very exciting. We've been waiting for, inhalation treatment of lung cancer for years. And the big inhibitor was that, well, once you find the lung cancer, it's already metastasized. We got to give them systemic chemo. And, thank you very much, but we don't trust it. So how are you getting around that old inhibition?
Yeah. So, with immunotherapy, The indication changed for inhaled chemotherapy because now the advanced patients were treated with anti-PD-1. So, of course, the inhaled chemotherapy need to be used with conventional standard of care. And for the moment, it's immunotherapy with IV chemotherapy. So the aim is not to replace IV chemotherapy, but to use this modality during the off cycles, because the patients are treated once a month or once, and after he has 1 to 3 weeks without any treatments. And so the aim here is to treat the patient during the maximum of the off-cycle period, to increase the response from the immunotherapy, because cisplatin is a cytotoxic drug, so he releases some antigen from the tumor, and like that you can increase the immunotherapy response. And also it could act by itself because it's a cytotoxic drug. So the aim is to combine, not to replace.
Thank you.
And a very last
A quick question and a quick answer.
Yeah, Darren Murnane from the University of Hertfordshire. I guess so you're talking about this being a DPI therapy that will be taken at home and used on multiple days at home. I guess that does raise some concerns, which is that there's going to be a cytotoxic drug left inside a reusable inhaler. Is that something that you've talked about or thought about? Because that's going to lead to exposure to people around the home, for example.
Yeah, so of course we have thought about that. So the aim is to use a disposable dry powder for inhalation. The aim is to have the capsule or the powder inside the dry powder that you cannot open for the patient. The patient will inhale the powder, so without inhalation you cannot activate the aerosol, so you limit the environmental exposure. And then we need to put the device in a plastic bag and to put it in hazardous drug waste. But yes, the aim is to increase the quality of life of patient and allow the patient take this kind of medicine at home, of course.
Thank you very much. Apparently,
Thank you.
your work stimulated a lot of discussion, so feel free to catch her later. Thank you again.
Thank you.